I have a couple moles in the dental department at UCSF, and one of them, as I was in his dental chair, told me that they were using silver nitrate. Is this true? Do you know what I'm talking about? Silver nitrate is an anti-caries treatment, and it's used in a global...
Well, so I can respond to this question.
Okay. Probably stick to the presenters.
That's right.
Maybe since I'm the only dentist, the pediatric dentist here, I'll respond. We don't use silver nitrate in our clinic yet. I know it's being used by several clinic trials and by Dr. Milgram, and a lot of projects that aboard. When I was trained as a dentist, general dentist in China, we used it in China as well as one of the anti-sensitivity. It has very strong antibiotic potent, but also can arrest progressing lesions. It does stain the teeth, though. I think it's probably a very good measurement. That's my own view. Methodology using in underdeveloped country when the care is not be able to give in. But in my own view, it's going to be really, really hard to use for young children moving around and use as a prevention regimen when you don't see the decay that's started yet.
You have a comment?
I'm really struck listening to the talks this morning and then this afternoon, how similar the problems are locally and globally, and how similar some of the approaches are. And it seems that we really could, working in communities, really learn from each other. And I don't really know how that frames into a question because it's a question in my mind. But have you, in designing your projects, particularly the medicine and nursing, did you look to other global models, or where did you come up with your ideas?
So we came in at the end of an Elevate project that had been developed by Alameda County and the La Clínica de la Raza Native American Health Center and Lifelong Health Centers, and they had developed, Alameda County had developed the dental model, and School-Based Health Center had been around. There are about 30 in Alameda County, so that basic model was also developed. So we kind of came in at the tail end of that project, and our charge from Atlantic Philanthropies was to increase sustainability. So we didn't really have a chance to change the model. However, we have been working really closely with community partners, and they have a lot of ideas about the model. And the next phase we're going to get grant funding to do analysis and dissemination, and we're going to definitely do that as a kind of community-based participatory model with our clinic partners to kind of really look at what could be a better model, and that would be a great time to actually look at models around the world. Great question.
Okay, next question.
Yeah.
Hold on. Is there another?
Well, I just wanted to comment in medicine that there's a huge or sizable emphasis now in training primary care providers to provide oral health assessment and supervision for families in pediatrics. Also, the national guidelines and the Oral Health Resource Center at the MCHB have certainly had a very strong influence on the development of our model involving non-dental providers and making sure to meet women and use the opportunities where women will be who need this work and need this education and skills building experience to be able to provide that for them. And luckily, centering pregnancy, which is a very efficient way to deliver prenatal care that really has a very strong emphasis on education and skills building. For us, it was a perfect place to add an oral health piece, and it's totally consistent with the guidelines and other agency priorities.
And I think looking at the model as a continuum, we tend to sort of be siloed in different areas, but I do think that continuum prenatal through adulthood is really we need to be looking at it as a broad model rather than each of us looking at our own specialty areas. And we're beginning to do that, whether in our professional work, in our disciplinary work, but I think there's definitely more we can do. And I think looking at these models each one of us have and join them, like with the discussion we've had today, I think is really the basis for improving health outcomes, oral health outcomes.
And I just want to add a little bit of it, being lucky that got involved with Lisa and Adam's project as a clinician scientist. I'm really, really enjoying that being included as a part, especially interdiscipline, because my interest is in children with the cavities, but also interested in how the microbiome. I think that's a lot of things I discussed with Mohammed too, that with all those projects, I was super excited even this morning in those global health project, because although we are on the basic science arena, and my view is understanding both sides, that we can probably bring some of the sides we learn from each other that actually really getting to the bottom line of it. I was really lucky because I involved a little bit in Tom Boyd's project as well. So dental caries is much more complex. It's the same as the oral cavity is a part of the total body health. And we're going to, I think, with all the development of this technology, there's going to be so much more we can understand and come up with solutions and be more integrated, not only on the just public health or global health level, but also how have the basic science integrated to help us solve some of the programs and figure out the mechanisms. And as one of the examples I see, silver nitrate fluoride is great antibiotics, but currently for all the antibiotics we use in prevention of dental caries, they're all white spectrum. We kill everything, but when we kill all the bacteria, like Mohammed mentioned, we are killing both friends and enemies. So we want to know, actually, probably it's better to have more targeted treatment, that we target enemies, and instead of wipe out everything, we just keep them balanced and happy community like the community we're having here.
So in trying to keep things balanced and happy, we'll try to move on to the next question as well.
Thank you very much for the wonderful presentations. My question has to do with the model. That was great, but if you were to scale up the model, one component that we often forget about it is how do you build? To be sustainable, you got to think of how am I going to build this? Who's going to pay for it? And one of the challenges that we have really in systems where things are billable is that the intervention itself, if the intervention is going to be done by a provider that is not a dentist, or then that, let's say, an assistant or a community health worker does not have the ability to bill that, to send the bill. So that's something that you may want to think about it. In other words, the procedure is in the ICD code, and the ICD code becomes later, reimbursable. So often we forget about, when we do models, this component that is very critical. So that's one of the things that I want to just kind of ask, whether you're thinking also about looking at how will this be sustainable in the long term. What kind of things do I need to be able to build this so then, it can be successful and you can scale it up? Thank you.
So maybe I wasn't clear in the presentation, but in that sort of the mass dental screenings, there was always a dentist. And the dentist actually was the official examiner of the teeth, sometimes usually with a student. And so the dentist billed for each screening. And then we had a lot of students and other lower paid folks doing the varnishing. But every visit in that screening was actually billed by a dentist. But the other thing I wanted to say that's really great is that a lot of the kids don't necessarily have coverage. And when the dental clinic is embedded in a school-based health center, there are a lot of mechanisms for getting kids through Gateway into Medi-Cal. So if the kids also needed immunizations or hadn't had a physical, and we found that kids with serious oral health problems often had missing immunizations and hadn't had a physical, then we could actually sign them up for Medi-Cal while, on the spot, while we were doing a physical or giving them immunizations, and then they would have 2 months at least of coverage to get the dental care that they needed. So it was a kind of a nice symbiosis. And I totally hear what you're saying about scaling up, because I think the more you scale up, the more you want to use people that can't bill necessarily.
I just want to add a little bit to the Canberra pilot study that we did. That definitely was one of the factors in the inability to bill for a lot of the procedures or the products, especially. So it made it very difficult to imagine sustaining a Canberra project beyond just that summer period that we had.
Person over there.
I was thinking it was really interesting to think about what you were talking about this afternoon compared to this morning. And this morning we talked a lot about global health and had some really great examples of some of the work that's being done and the focus on prevention. And a lot of that was really talking about nutrition. And I was struck by this afternoon, we learned a lot about programs, but not as much about the prevention aspect and thinking about how nutrition has played a part of the programs that you've done. And I'm sure that when you work with women who are pregnant and in schools, there's been messaging about nutrition, and I was wondering what kind of lessons learned and what kinds of things would be helpful for us to know about, because there's a lot of parallels from what we heard this morning, a lot about why Coca-Cola and snack foods have really contributed to this problem, and we know that that's also part of the problem here. So if you could share with us some of the parts of nutrition that you've used for your messaging would be helpful.
Do you want to start?
Sure. So in our Centering Pregnancy CPOP project, that is a critical component in both the maternal and the infant oral health module that we developed. So like Sally was mentioning, we did use the guidelines that are evidence-based, the clinical guidelines, to develop our learning objectives. And so we do have a strong message around minimizing frequent sugary snacks throughout the day for the mom, as well as proper feeding practices for the infant. And then we train the nurse midwives or the facilitators in those objectives, and then they deliver it in their setting.
And just in our setting, we ran into an issue because they definitely got the message about less frequent snacks and less frequent sugary snacks. The problem is that in middle school, the kids are in puberty and they're growing and they're hungry constantly. And so to tell kids not to snack when they're always hungry is really difficult. And so there have been a lot of other nutritional initiatives, and there's a kind of centering obesity, although we can't call it that because it's not part of the centering group, but there's group obesity interventions in 3 of the health centers that also have to do with nutritional interventions, but we kind of noticed that that we don't always give the same message when we're talking about obesity as we do when we're talking about oral health, and we're trying to figure out how to put those together.
And I think the other piece that was the Take Back the Tap, which has been a very successful campaign, and just getting kids to understand the components of sugar in the drinks that they're drinking and thinking about actually drinking tap water. Most of them have been trained not to drink any kind of tap water at all, or certainly water at the school. So just small things make a huge difference for them during the day. And not that we were able to reach everyone, but certainly we did reach a fair number of kids, and really having them think about that as a change in health behaviors. So I think that's really key. And also just in our training program, certainly for our nurse practitioners, we fundamentally talk about nutrition both in infancy and beyond, which is a big part of what you mentioned in terms of the frequency of feedings and how that's so contributory to early childhood caries. So there is a theme, but it may not have come up as much in the presentations today. So
we have to take one final question, and then
anyone else? If not, I can.
If we have more questions, then speaker afterward.
This morning and this afternoon sessions, there's been a sort of an assumption that low SES poverty has high caries, higher risk, and the reverse. High income, high SES has low caries. And that's obviously true in the United States right now. But in the world, we saw this morning, poorer countries had lower caries and richer countries had more caries. And if you go back to the 1962 federal government N. Haynes report, you will find that the high income, high education Caucasian group had the highest carries, and the non-Caucasian, non-high school graduate, low income, had half the DMF teeth in the United States in 1962. After that was Crest toothpaste and the poverty program, which meant food stamps. And it was completely reversed as it is today. So we can't just, it's not even simple as we've been saying, it's complex. Poor people can have less cavities depending on the practices.
I agree. It very, very much has to do with access. And when the slides that I talked about were, of course, really representing a lot of the work we've done right in the Bay Area, but it's access to nutrition, high nutritionist food. And now we're seeing that much more with the high SES than the lower SES, but just this availability of good sources for food. And so I agree. There's been a definite switch in that over the past several decades for a number of reasons which we're aware of.
So thank you so much for the panel speakers. And if you have any further questions, please vote the speakers afterwards. Thank you.